Well, thank you for coming to this seminar in the morning. Actually, I couldn't sleep well last night, not because of this presentation, but because of some of those what's going on in the other continent. Anyway, universal health coverage is an essential element of the so-called Sustainable Development Goals, especially SDG 3. Well, universal health coverage means that we ensure access to healthcare for everybody without experiencing the financial hardships. Okay? So to achieve that goal, we want to maximize the role of the public sector financing. Okay? In the history of UHC, almost no country has achieved the UHC relying mainly on private sector financing. So public sector financing should be the major pillar of financing for UHC. So public financing means it can be either taxation or so-called mandatory social health insurance, often called as a national health insurance. And by relying on those public sector financing, we can minimize the out-of-pocket payment at the point of service of healthcare utilization. But if you look at the evidence in Asia, unfortunately, there's a huge out-of-pocket payment that account for the big lion's share or major component of healthcare expenditure in most countries. And as a result of this huge out-of-pocket payment, people definitely have a financial barrier to access to healthcare. Or when they use healthcare, there's a huge expenditure that is often called a catastrophic healthcare expenditure, or people become poor as a result of huge healthcare expenditure. It is called the impoverishment impact. But, we cannot achieve UHC in a short time. More realistically, it takes many, many years for many countries to achieve UHC. So we need to pay attention to the progress or process of UHC, and we should pay attention not only to how many people are covered, but also what percentage of healthcare expenditure is covered by public scheme, or what percentage of cost is accounted for by out-of-pocket payment. That means, so which service, not only how many people to cover, but what kind of services are covered and how much expenditure is provided, supported by the public scheme. And also we should pay attention to the vulnerable population, equity issues. Okay? This is a snapshot of financing mix of healthcare expenditure. In Asian countries, just simply speaking, red part shows a private sector financing, mainly out-of-pocket payment. Another component of private sector financing is a private insurance. But in the majority of low-income countries, the role of private health insurance is quite minimum. So in most DMCs in the context of Asia, red line private sector financing mainly means the out-of-pocket payment at the point of service, whereas this one, blue one, is the public healthcare financing, and taxation, as I mentioned earlier, public sector financing means either taxation or mandatory social insurance scheme. So this one means it's a social security, social mandatory health insurance scheme. The blue one is a taxation. And some countries, especially many Pacific Island countries, they heavily rely on taxation. And you can compare these previous slides with the OECD. This is OECD picture. You can see, if you look at OECD countries, the role of red one, the role of private sector financing, either private insurance or out-of-pocket payment, is very minimal. Then now I'll examine some of the major components of UHC. First, how to ensure more people have access to healthcare, so-called population coverage issues. First, there should be a mandatory public financing. As I mentioned earlier, in the history of UHC, No country has achieved UHC relying on voluntary private sector financing. There's a principle of social solidarity. As I mentioned earlier, we should rely either on taxation or mandatory or social health insurance. Usually in those schemes, our payment is dependent on our capacity to pay. If it is voluntary, the better off are they willing to pay more for the same amount of type of services? Usually not. So that is a case that we often quote the US example. US spends 18-19% of GDP on healthcare, but still does not achieve UHC because they have still relying mainly on private sector financing. And as I mentioned earlier, this income-based contribution is not possible in voluntary financing. So if you look at all OECD countries, they all rely either on taxation and social insurance. Of course, it's not all, so there's always a supplementary role of private insurance. But major pillar of financing should be either taxation or social insurance. And also, political mobilization and commitment is the key. China and Thailand are often quoted a good best practice examples of UHC or rapidly achieving near UHC in the case of China. There's no secret. The governments poured a huge amount of public funding to the healthcare system. And also unique ID or information and communication technology infrastructure can be a quite effective tool to achieve UHC. If you look at the India, the example, RSBY, social insurance there, they have a very good ICT technology to manage enrollees and manage the unique ID system. And also social marketing or literacy, communication is another important issue because like public insurance or social insurance is still a new concept. So we should have a very active, proactive social marketing to improve the awareness, what does the UHC means and how to achieve it and what are the roles of public sector financing. Where the money comes from? As I mentioned, we cannot rely only on sources. So we should rely on different sources, so various sources of financing. But for efficiency perspective, we rely on many sources, but we pool those sources into one single big pool to maximize the so-called purchasing power of the purchaser. But different countries depend on different types of public sources of financing. In Japan, Korea, Taiwan, in Asian countries, they mainly rely on mandatory contribution through social insurance. But if you look at other countries like China, Thailand, more than half of the public funding is coming from government taxation. Like Thailand, people in the formal sector employment, they pay contribution. But people in the informal sector, they don't pay contribution. Government fully subsidizes their insurance contribution. Whereas some innovative ideas in some countries like Ghana in Africa, they use some portion of value-added tax and channel that in the health insurance. And also in the case of France and the Taipei, China, they earmark some portion of non-wage income for healthcare, like a capital income. So they, as I mentioned, use different types of sources of funding. Which services to cover? Because we cannot provide, or we cannot cover every services. We should prioritize which services to cover, or which services to provide, at the beginning. So in theory or in principle, the UHC and public scheme should provide a continuum of care, or so-called integrated delivery system from primary care or even prevention, promotion, primary care, secondary care, and tertiary care. And these days, we are facing population aging. So even the aged care or community-based social care. So we need a mentioned, since we cannot cover every services, so we need a good priority setting for essential services or basic benefit packages. But in many Asian countries, this so-called essential or basic benefit package is still very loosely defined. So there are a lot of controversies and a lot of some politicking around these essential benefit packages. So what we should do is we should institutionalize a formal process or transparent process how to define this basic care. So in this institutionalization of the process for defining benefit packages, I think there are two important kind of paradigm. One is evidence. We need a good evidence. Which services work, which services doesn't work, or which service is more cost effective than other services. So economic evaluation or cost-benefit, cost-effectiveness analysis is very important to produce evidence of these on-benefit packages. But evidence is not enough because there are many equally or equally cost-effective services. Let me give you an example. Which one is more important for your view? One, smaller amount of benefits to larger population, larger amount of benefits for smaller population, like a rare disease. Which option is more important in terms of which option should be given higher priority in the decision making? Is it evidence driven? No. Evidence alone cannot solve these issues. It's more like ethical decisions. So value judgment. So for that type of decision making, we need to have some mechanism, like in the UK or Korea or Thailand, we have a so-called Citizens Council. So select, like similar to the jury system in the US, invite lay people and have a discussion, deliberation for like 2 days and get to the conclusions. Purchasing, because like a typical social security scheme is one is a pension, the other is healthcare financing. The major difference between pension and healthcare financing is that in pension there's no service provider. But in healthcare, we do have a service provider. Those service providers are very powerful, knowledgeable in many aspects, medical doctors, hospitals. So how to deal with these service providers is a very essential component in the UHC. So the goal is how to maximize the purchasing power, because purchasing here means a healthcare financing agency or the government purchase services from healthcare providers for people. So in that sense, single big pool is more efficient than many smaller pools, because we can maximize the kind of purchasing power with a single pool. And also we need a good capacity and good incentive mechanism for those purchasers. And we should revitalize primary care. Because, primary care or public health centers or physician clinics in the primary level in the community, they should be a good gatekeeping, because not everybody needs to go to the big hospital. So they should be a good gatekeeper, allocate patients to which level of healthcare providers to be treated. So gatekeeping is important. And these days, we have a lot of discussions on infectious disease and health security. And primary care providers, they are the frontline providers, and to the monitoring and evaluation as well. And these days, we talk a lot about continuum of care, especially for old people in the community. They need from primary care to a community-based social care. They have a multi-morbidity, not just 1 or 2 diseases, but 5, 6 diseases. Who should be the focal point, a focal person to provide continuum of care for this older population? Is primary care, or prevention and promotion to non-communicable diseases also. For this sector, primary care doctors are important. Now, we talk a lot on aging issues. Universal UHC is also quite important for aging, because our goal is provide access to care to everybody. regardless of age, regardless of financial status. Basically, we focus on the healthcare in the whole life course, not just childhood, not just adult, not just old, but from childhood until our death. So we need to extend the benefit coverage because currently, still in many countries, benefit coverage focus only on communicable disease. But with population aging, there are more and more importance on non-communicable disease. So the benefit package should include the the non-communicable disease for all the people. And also another important perspective from financing is that aging means and more people live as a post-retirement age. So if our financing mechanism rely only on formal labor market, then that financing mechanism faces fiscal instability. So we need to more diversify into like a taxation to take into account that more and more people, they live longer life after retirement. And also continuum of care is quite important. We should overcome the discontinuity, fragmentation. So we should provide integrated care for the whole population. This is old age dependence defined as older people divided by a people in the production age. There's a huge and rapid increase in dependency, old age dependency. The leader in our region is Japan. But right after Japan, there are two countries following a very similar pattern. That is Korea and Singapore. But after Korea and Singapore, there's another two countries following a very similar example trend, China and Vietnam. So you can see that population aging is really becoming a serious issue in Asia. Final slide. What's the implication for ADB, for this UHC? What we can do? What is our competitive advantage? So as I stressed it previously, integrated delivery system is quite important. One of the misunderstandings of UHC is that people think UHC only from a financing perspective. Of course, we should raise enough public financing, taxation, mandatory insurance contribution. But without a good delivery system, what's the role of financing? So we should have a good service delivery. And good service delivery means a good integrated service delivery from very basic primary care to secondary care, tertiary care, and even post-acute care, rehabilitation, community-based care for all the people. So we should strengthen this good integrated service delivery, which is a very essential component of UHC. So in that sense, ADB has a long, good reputation, and we have a good history of investing a lot on the infrastructure. That is still valid and very important component for UHC, like urban health in Bangladesh and India, and also we are thinking of doing something in the grassroots healthcare system in Vietnam. That's the key, basic, essential infrastructure for UHC. And so strong public health centers and also referral hospitals. So integrated service delivery is one of the key words in the UHC, and ADB can, and we should do a lot of contribution to this sector. Another important element is the so-called investment in health argument. Spending on health, is it just a spending? No, it's not just a spending expenditure, it's an investment. If people live longer, healthier, it contributes to economic growth. If you have the data from many low-income countries around the world, increased life expectancy always results in increased investment in education and training. If you live longer, you are more willing to invest in education and training because you have a longer time to enjoy the benefits or returns on your investment on education. So, and also capital, people tend to save more when they live longer. So healthy population means a higher labor productivity, more capital accumulation, resulting in economic growth. So our counterpart is Ministry of Finance, and we should really have a good policy dialogue with the Ministry of Finance in terms of the investment in health arguments. Finally, multi-sectoral approach. Our goal, UHC is important, but is it UHC is the final goal? Of course not. Our final goal is a better health, more equitable health. Then what is the best way to achieve better health? UHC is one of the essential components, but we know there are many other so-called determinants of health. Healthcare is one thing, but like a safe water, environment, sanitation, also affects health to a great extent. And for this multi-sectoral approach, we have the strength. Because we have very good track record in urban sector, transportation, water, sanitation, environment. Transportation is also important. If you don't have a good road system, you can imagine how it takes days to transport patient from rural area to the healthcare center in urban area. So good transportation is another very important element, determinants of health. So for this multi-sectoral approach, ADB is a good position or strategic advantage to mobilize these multi-sectors to achieve the UHC and better health of the population. Thank you.
Thanks very much. It was a really interesting presentation. You said at the beginning that almost no country has received the optimum health sector performance or development through private sector. Which are the best examples of the private sector, and which examples would you encourage the private sector to move into more?
Oh, well, in my view, in my knowledge, among the OECD countries, there are only two countries which mainly relies on the private sector financing. One is Switzerland, the other is the US. Netherlands can be an example, but Netherlands is kind of, Netherlands have a very long history of a mandatory social insurance, but they kind of privatized, but nobody really thinks that's a private entity, okay? But Switzerland also, they rely on private insurance, but majority of almost all people have some kind of private insurance. So major kind of example, the relying on private insurance is the US. Okay, with the exception of the US, as I mentioned, Switzerland, all countries in OECD countries, they mainly rely on public sector financing because, as I showed in examples, if you rely only on private sector financing, it's really difficult from both theoretically, from empirically, it's not easy to achieve like a universal health care coverage, like similar to the primary or secondary level education. If you leave it purely voluntary basis, can we achieve a universal primary education for all? Maybe not. Okay? And also, private sector has a lot of, so my perspective, our kind of consensus among expert group is that in terms of financing, the public sector financing should be the dominant major pillar, and private financing, like private insurance, play a supplementary role because public insurance cannot cover everything. Impossible or inefficient. If we have one single public insurance, it's a huge monopoly. It may be, very inefficient, inequitable, many problems. So major and minor role. But in terms of delivery, the story can be different. Because private sector can be innovative in some aspects of healthcare. So in the delivery side, we can be more accommodating more private sector in the delivery side. But again, we should be very careful. If you look at the former socialist countries, China, Vietnam, they still have the majority of the hospitals are public, But the government provides huge fiscal autonomy. The pros and cons. Pros, they treat a lot of patients. Cons, they behave like a reckless profit maximizer. They do not want to treat poor people. They want to provide a lot of new technology, very expensive, sometimes necessary, sometimes not necessary. So in the delivery side, we are supporting public-private partnership, but how to implement public-private partnership in taking into account the context of each country. That's the major kind of a deal.
Yes, Ujong, please. Ujong, and then here.
Yes, thank you very much. Very, very interesting. The point about the role of Ministry of Finance, it is very important to deliver our services to the countries, and knowing that the health issue is a very important, will be an important pillar for our long-term strategy. We have to think about how to, make sure that the countries know that we can do this work and, in a way, create demand. Maybe just one suggestion. I mean, I think this is really interesting, but more people need to know about these issues, especially the finance people who are not necessarily the health people. About 10 years ago, in the water sector, what we tried to do was we picked like 6 countries where we really want to scale up, and we organized a water financing conference focusing on these 6, and we brought in the water ministries and the finance ministries, and we had the plenary sessions, and we actually had separate meetings to talk about country-specific issues to help create the demand. So you might want to consider something similar,
Right.
for this topic to really create. I mean, unfortunately, she left, but at least you have the operations people who need to work together.
You're right. Ministry of Finance, all countries, very powerful. And also, even if a country has a good mandatory social insurance contribution-based system, but still government budget allocation is one of the key elements of healthcare system. So we should really have a good policy dialogue and good communication between Ministry of Health and Ministry of Finance. Oftentimes I found they have a different language, right? Ministry of Health people, their language is very different from the Ministry of Finance. Myself, I'm an economist, finance background, but I've been working in the healthcare sector. I can communicate both, but still, there are a lot of communication issues. So these days, we tend to have more and more forums and workshops, conferences, inviting both. So at the end of September, we have a flagship conference for 4 days. We invite both, Ministry of Health, Ministry of Finance, and also some health insurance agencies, because without persuading the Ministry of Finance, UHC cannot be possible. So you're right. I mean, we should work more closely with the Ministry of Finance. In that sense, bank has an advantage because we have a good kind of relations with the Ministry of Finance.
Good morning. Thank you very much for the very interesting presentation. I have a question on access.
Mm-hmm.
How do you measure access? Financial protection is quite easy, but is there a single indicator or set of indicators which allow the comparison between countries or the progress within a country?
That's a tough job because a few months ago we have a big discussion with SPD on what's the correct measure for access for healthcare, like water, energy. I mean, they have a very clear indicator. Service delivery, but in healthcare, suppose we built like 100 public health centers. Does it mean that the people in the catchment area have an access to public health centers? Maybe or maybe not, because there may be some additional financial barriers, geographic barriers, or cultural barriers. So it's always controversial, still controversial. So recently, the SDG committee suggests that how many people are covered by health insurance as a measure of access, or SDGC. And that's a huge controversy. And many organizations are writing a petition letter, this indicator is wrong. So that's a still controversial issues. And one of the options we discussed a lot through the emails a few months ago, but like how many people used the specific health services, and equity perspective with like a gender, economic status disaggregated. But we should work hard to elaborate, and we cannot rely simply one or two measures. We should rely on multiple measures. But also financial protection is not easy, because financial protection, we have to rely on kind of survey data, household survey data, rather than a whole population data.
Well, that's why we published a working paper on monitoring and evaluation of UHC, which looks at all the components, input, output, and also the aspects of service delivery, determinants, etc. It's a publication that we did together as WHO as a suggestion how you can improve measurement of UHC. So access is defined there.
Maybe let me ask you a question about prioritization. So say I'm a minister of health in a country, very poor, and I face all the problems. How should I prioritize my actions?
My answer, strengthen the primary care system first. Strengthen the grassroots, commune primary care systems first. And even those primary care centers, like primary centers in disadvantaged areas, rural, remote slum areas. So that's why I think that our approach for urban health or commune health in Vietnam, Bangladesh, India is the right approach. That should be the highest priority.